Okay, well, I'm getting this same kind of frozen screen, but hey, I hope you guys are doing well. We're going to go ahead and get things started today. We're going to look here at some of these different medications that are going on with the endocrinology system. It can be a little overwhelming at first, but keep this in mind that most endocrine disorders are caused by too much or too little of something. So it's pretty cool. You can either increase or decrease. Typically, it's a hormone or some other kind of signaling molecule to get the body to do more or less of something. So that's pretty cool. So we can add medications and we can replace if we need to replace something or we need to turn something off, or we can add medications if we need to turn something on or turn something down. So there's a lot of things that we can do with the endocrine system, which is really cool. And so it's basically a bunch of on and off switches until we want to get the lighting levels just quite right, if that makes sense, or some other kind of image like that. So let's kind of go through some of these different pieces here. Here we go. So kind of here's before we get too started in here, up if you're following along on your notes or on the screen, I invite you to take a quick scan at this QR code here. That lets us know that you were here today and lets our funders at the Parkview Foundation lets them know that this is a useful tool for you. And for those of you who've been hanging in there with us and your test scores are improving, I'm really excited that you share that information with me. It gives me, it gets really jazzes me up. So let's take a look at just a couple of examples of the uh, endocrine system. So we have like the thyroid gland. And so if we have too much thyroid hormone, we get hyperthyroidism. And so we can give a beta blocker, which we've learned about, to help slow down the heart rate. Or we could give radioactive iodine to help to slow down or even kill off parts of the thyroid if it's working too much. Or if you have too little thyroid hormone, you can give some synthetic thyroidism or synthetic thyroid to help treat hypothyroidism, if that makes sense. So we can adjust those levels. The pancreas, we're all familiar with insulin. If we have too much insulin or too little blood sugar, that's hypoglycemia. So we can give more blood sugar in the terms of 15 grams of carbs every 15 minutes or so. So too little insulin, though, or too much blood sugar, and we get hyperglycemia. So we want to treat somebody with that. We give them some insulin to bring down their blood sugar. Sometimes we give them fluids and things. See, so it's not too crazy. The best thing to do is to review your pathophysiology, just in general, kind of get a pretty good understanding of what's going on with each system. And then you can better be in a position to understand the why. So if you understand that diabetes is a disorder of insulin, then you can understand if we add or subtract insulin, how that can help or hurt the patient. And that really helps us understand that. You can utilize Sauter's comprehensive NCLEX. It's a pretty good summary of what you need to know for nursing school because there's a lot there, but the comprehensive really helps to boil it down really well in these chapters here. Read and reread your notes from your professor, Professor Bays, for this particular class. And watch bot videos on concepts that you're still not getting. I've included a couple of links at the end of this presentation. So what we're going to take a look at, though, today is diabetes, and I'm going to do what's like the 5,000-foot view of the key endocrine disorders that you need to know to do well in your pharmacology class. And most of your NCLEX questions will come from these, especially diabetes. You need to know diabetes really well because a lot of people have diabetes and pre-diabetes in this country. And so it's a high yield topic. So you want to spend some extra time on it here, and you'll be getting it again in Med-Surg as well. So it's one of those that investing some more time here will pay dividends later, trust me on that. So let's take a quick peek at diabetes, and we'll kind of go through just the 5,000-foot view, and then we'll dive into each of these disorders in turn. Today, we'll focus on diabetes. But just in general, you have hypoglycemia, which is too little blood sugar or too much insulin. for the amount of blood sugar that's present. Or you have hyperglycemia, which is too little insulin or too much blood sugar for what's there. There are two subtypes of hyperglycemia. There's diabetic ketoacidosis, and there's what's called HHS, which is hyperosmolar hyperglycemic syndrome. And we'll talk more about these later today. So looking at the pituitary gland, like some problems that you have with those would be with growth hormone. You have acromegaly, which is too much growth hormone, or dwarfism, which is too little growth hormone. And we can usually treat acromegaly by going in and taking out the pituitary or doing some surgery there or medications, which acromegaly, someone's really tall. A friend of mine who had acromegaly, and she's about 7'2". And then, or dwarfism, too little growth hormone. And my wife and I have some friends, and two of their sons had too little growth hormone, and they were getting that to get taller. I'll talk about those next week. Too much antidiuretic hormone, ADH, which is like SIADH, is an example of too much ADH, which causes you to retain fluids, and so you're the person saturated inside. Or you can have diabetes insipidus, which is too little ADH. We'll again talk about that more next week. With the thyroid, you can have hyperthyroid from too much thyroid hormones, and that's like Graves' disease. And an emergency that we'll need to know for our NCLEX studies is a thyroid storm. Or you can, this should be hypothyroid. Here, that's a typo. Is too little. So we'll fix that typo. All right, so hypothyroid. So I like to go through these with you all before I send them out for a final go. Probably saw that my diabetes was misspelled up there earlier. We'll catch that too. Or let's say we have a disorder of the adrenal gland. And so that would be like Cushing's disease or Cushing syndrome. That's too much cortisol. And then you might have Addison's disease, which is too little cortisol. And the high yield thing that you'll want to know on this is an Addisonian crisis. And we'll talk about that next week. So today, what I really wanted to focus in on is just diabetes. It's a lot in itself. There's a number of different medications that are there, and it's just a lot of concepts. So I wanted to focus on diabetes. So there are two main types of diabetes. There's type 1, and that's AKA insulin dependent. So you can think about it this way. In type 1, the problem is none. There is no insulin in type 1 diabetes. So the beta cells in the pancreas that make the insulin are busted. They're gone. They could be a result of genetics or a viral illness or an injury to the pancreas. Something like that has created a problem with the amount of insulin that they have, and they don't have any. And so the signs and symptoms you'll see of this are going to be things like polydipsia, that means you're thirsty, polyphagia, that means you're hungry, polyuria, peeing a lot. Let's break down those words a little bit. Poly means multi or a lot, right? And dipsia means you're thirsty. You can always think about, so you're dipping in for some water. You're like, did that make sense? You're dipping for some water because you're thirsty. Polyphagia, phagocytosis is the process of eating. So polyphagia means you're eating all the time. Polyuria, you got urea, so you're peeing a lot. And the treatment is usually insulin with type 1 diabetes. Type 1 or type 2 now diabetes, which is insulin resistant. And you can think that type 2, the problem is you. And so the body is resistant or doesn't make enough insulin. And those risk factors typically have to do with too much weight. They typically tend to be folks that are heavier, and particularly with abdominal obesity, with hypertension, hyperglycemia, high triglycerides, and low HDL. That's the good or the high quality cholesterol. I remember HDL by thinking H for high quality and L for low quality. And I want to have a high quality cholesterol number, and I want to have a low quality cholesterol number. And if you have a low high quality cholesterol, that's bad news, right? So if you're taking a look at your HDL numbers, These are risk factors that you should know for your exam. They'll pop up on the occasional NCLEX questions like, what are the risk factors for diabetes? There are also similar risk factors for things like atherosclerosis. It's going to be abdominal obesity, hypertension, hyperglycemia, high triglycerides, and low good cholesterol. And by improving these medications, sometimes patients can get off of medications, which are really cool. Because maybe your body is capable of treating your blood sugar by having you have enough beta cells in your pancreas to maybe treat a blood sugar that gets to 200, but you can't treat it if it's over 250. But if we can keep your blood sugar less than 200, if that makes sense, then you'll be better, and you might not need medication. So that's kind of a neat thing about type 2 insulin is sometimes we can reverse it, and we don't have to make the person totally healthy to reverse it. Sometimes it's just as little as losing like 10% of somebody's body weight. So that might be, if you're 200 pounds, that might be losing 20 pounds. And that might be enough. So it's not uh, it's not a forever diagnosis. Type 1 diabetes is a forever diagnosis. Type 2 is not. It can be reversible. So these are some diagnostic labs. You really should know these, especially know the normal blood sugar should be somewhere between 70 and 100 is usually the number they go with, or 70 and 115 here. This is from Simple Nursing, this graph table. So that's helpful. You also want to take a look at the HbA1c number. This one is the one that you need to know what this number is, what this means. And so the HB, that's the amount of sugar that's basically on your red blood cells hanging out there in your blood sugar. And it's what your blood sugar is doing over a period of time. And so you want to have this less than 65. If it's greater than 65, it's technically diabetes. And the way I think about this is 65 is when most people retire. If you're going to be in pre-retirement, if you're 57 to 64. And if you're just normally employed, then you're under 5.7, if that makes sense. If you're under 5.7, if you're under 57 years old, you're still in the workforce. Maybe if you're 57 to 64, you're pre-retirement. And if you're 65 or 6.5 or higher, then you're retired. Well, you've got diabetes if you've got an A1C of 6.5 or higher. So a normal range for blood sugar is 70 to 100. When we have hypoglycemia, that is too little blood sugar or too much insulin. And so the thought behind a good way to remember that is if the school is cold and clammy or cool and clammy, give some candy. If they're cool and clammy, give some candy. You'll see things like hunger, nervousness, palpitations, tachycardia, tremors, confusion. If it gets worse, it's double vision, headache, irritability, slurred speech. If it gets even lower, you get loss of consciousness and seizures. I had a friend of mine when I was in high school, and he had a seizure due to low blood sugar. It freaked me out. I didn't know what was going on. But we were on the store to get him some food for lunch. We were all getting lunch in high school break, and he had a seizure in the parking lot. And there was low blood sugar, and so he was fine after he got some glucose into his system. He was good. But if we had known his signs and symptoms, we'd known he was a diabetic, we probably would have moved a lot faster to get him something. But he didn't tell us because, well, kids in high school don't want to be different. And so we didn't know he was a diabetic until we needed to know he was a diabetic. So that's one of those stories where you can kind of see where Erickson's stages of development come in, where high school kids don't want to be different. So they'll sometimes hide their issues from their friends. One of the things to know is that beta blockers, we get beta blockers for like elevated blood pressure and elevated heart rate. It can mask tachycardia, right? Because it slows down the heart, which is a sign of hypoglycemia. They can also help perpetuate hypoglycemia if they're not cardioselective. So we want beta blockers if someone is either an asthmatic or a diabetic to be cardioselective. Otherwise, those beta blockers can affect glyconeogenesis, which is the formation of glucose from the muscles. So, how do we treat hypoglycemia? Well, if they can swallow, you want to give them 15 by 15. So that's 15 grams of carbs, and then you want to wait 15 minutes. And so those are going to be things like, oh, I don't know if there's not one list here, but it'll be things like a couple of hard candies. Often you'll see like 4 ounces of orange juice in the hospital or things like that. So you want to give them some grams of carbs and you want to wait 15 minutes, 15 grams of carbs, wait 15 minutes and reassess them. If they can't swallow, but they have IV access, you can give them D50, which is dextrose. And it's a kind of syrupy, it's like corn syrup, mix of water basically, and you're just pushing it in to their IV or dumping it through their IV, and that will help bring their blood sugar back. If they can't swallow, really important, don't give them something to eat if they can't swallow. This is often a test question. It'll be like somebody is comatose or they're lethargic and they have a blood sugar of 40. What do you do? And one of the questions will be like, give orange juice. Be like, yeah, let's give orange juice. The answer is no, you don't give orange juice to somebody who can't swallow. Who So if they can't talk to you and they can't swallow, don't give them anything by mouth because they'll choke on it, and that's bad news. So they may have glucagon with them that causes glyconeogenesis to happen. So that's a medication that you can give. Um, there's some other things in there. I tried looking around. I've read things like putting honey on people's gums so you can get it, so you can get some blood sugar being absorbed buccally, so they're not swallowing it, but like they're putting it up in their cheeks and in their gum tissues. And I think that may work. I don't know. Um, I was trying to find some guidance on that for emergency medicine and out in like when you're hiking or something like that. And I couldn't come across something. So if you know, let me know because I'd love to know the answer to that. So let's take a look at this from this table. This is from osmosis. Um, so low blood sugar is going to be less than 70 in adults. Remember, 70 to 100 is kind of the normal. Um, and it's caused by usually too much insulin or too much diabetes medication. That's typically the problem if you have diabetes. Or if you don't have diabetes, it could be not eating as much, or maybe you're exercising more, or you're drinking too much, or you have some underlying conditions, or medications that can cause that. So these are your symptoms. These are always good to know. You will need to know these for your NCLEX: hunger, fatigue, shaking, sweating, pale skin, dizziness, and if it gets worse, confusion, slurred speech, blurred vision, fainting, seizures, coma, and death. So how can we take a look at these? We can group these. These are all going to be, this is what happens when you're hungry, right? You got low blood sugar and you're hungry, you're fatigued, or maybe a little angry, you're moody, right? You don't feel good. What's your body telling you don't feel good because you're hungry? And then these are all neuro issues. Um, Seizure, coma, death, right? Fainting, blurred vision. And this is because now we're starting to affect um, what's going on in the brain in terms of osmolarity as well. And the brain doesn't have enough sugar to function. The brain runs on glucose. If you don't give the brain glucose, it's going to die. Um, so you give 15 grams of carbs times 15 minutes. So, and you want to do fast acting carbs. This can be sugary pop, orange juice, candy, things like that. You wait 15 minutes, you test again. If you don't have that, then you can use a glucagon injection, and you're going to go at 90 degrees into the thigh or the buttocks. It's kind of like an EpiPen. Looks pretty much the same. All right, so let's talk a little about hyperglycemia, and that's going to be when you have too little insulin, and you can be hot and dry. They say if you're hot and dry, then the sugar's high. So that's kind of the saying there. Looks like I gotta finish that statement in there. DKA is diabetic ketoacidosis, and we'll talk about that just a moment here. But that is um, more common with type 1 diabetes. And so that's high blood sugar, but in type 1 diabetes, you're not making any insulin. And so that means no insulin, means no carbohydrates, no glucose can get into the cells. And so the body can do things like break down fatty acids, and that's what it does. If you go back to remembering your anatomy and physiology there, what happens with the cycles and making ATP, and what happens when you don't have glucose, which makes a bunch of ATP. You can use fatty acids, but as a byproduct, you make keto acids. And so you can put your body in ketosis. And so if it's too high, you'll start to see things like what's called Kussmaul breathing. And these are fast respirations to blow off the extra CO2 and to reduce the metabolic acidosis. And you'll hear things like in endoclex questions, you'll see like patient has a rotten odor or a fruit breath odor or a fruity odor or an acid, odor that smells like fingernail polish. Well, that's the acetone from the ketones that are what you're smelling there. It smells kind of like rotting fruit. And the treatment, IV fluids. You want to get this person back up to being fluid hydrated. Potassium keeps insulin in the cells. And so when there's low potassium, the insulin starts to pull out of the cells. Remember, most of your potassium is inside your cell. And when there's no insulin to be the gatekeeper, it comes out. And so then you can also get regular or short-acting insulin. Often IV, and then that we require frequent monitoring of blood glucose levels and potassium levels. I've taken care of some patients like this. They're usually in the ICU, and you're usually checking their blood sugars every hour. And there's a sliding scale as far as where are they? Do we need to start giving them insulin? Do we need to keep giving them more fluids? Do we need to give them more potassium? There's a lot of just making sure that those levels are okay. So a patient like this may eventually be given some D5 normal saline. You might be like, well, why are we giving them dextrose if their blood sugar is already high? And that is a brilliant question. And I'm so glad if your brain went there, because that means you're starting to put these pieces together. Yeah, we give some measures of blood sugar, or some measure of blood sugar, to help decrease the risk of intracranial pressure with people with high blood sugar. And it seems a little counterintuitive, but you want to think about it this way. If we have high blood sugar and we drop it suddenly, we're creating an osmotic difference. And that can cause the brain tissues to swell, and that can increase intracranial pressure. So we want to lower very slowly that high glucose thing. It's sort of the way I look at it this way is if you're flying in a plane and the pilot's sick and just don't crash it. You want to try to bring it into a nice gentle landing, right? So we don't crash the plane. We want to set it down gently. And that usually means titrating in a little bit of dextrose. So that's why that can be used for that. So the next one we have is hyperosmolar hyperglycemic syndrome, HHS. And this is more common with type 2 diabetes. And they have some measure of insulin working in their pancreas. And so they don't have the same type of ketosis because they have usually enough insulin to prevent the cells from starving. And it's starving, when they're starving, that's why they make ketosis or ketones. And I'll talk about that in just a moment. So similar to DKA, there could be some metabolic acidosis. So again, it's not as high because the metabolic acidosis comes from the ketones that are being made. It's not saying that it won't be there. It's just not as common. So if you see a question that it's talking more about high blood sugar and you don't see things like ketones in the urine or fruity odor, it's probably talking about HHS, especially if they're a type 2 diabetic. So the treatment, though, it's basically the same. So we will go back and we will still give IV fluids, probably give potassium. We may be giving some insulin, and we'll be doing frequent monitoring of glucose levels and potassium. And we may end up giving some D5 normal saline as we're landing that plane gently. So let's talk a little bit about insulin and DKA, because I think this can be helpful. And so utilizing a little bit of AI, I'm like, I need a picture of a bouncer outside of an apartment complex. And so I'm calling this apartment complex the cell. It's an ultra mod, trendy place to live and work, but there's only one problem, and that's the doorman. And his name is Mr. Insulin, and he's kind of an asshat. He's got one primary job to let glucose into the building, but he doesn't like to do it all the time, especially, and if you're a type 1 diabetic and you have type 1 diabetes, he never shows up to work for you. So management always has to call in and inject a substitute for Mr. Insulin if you're a type 1 diabetic. But they can, and those substitutes, they come and they work on 4 different shifts. There's rapid insulin substitute. He's like Uber. He comes on fast on super short notice, like 15 minutes, and he's there. Boom. But you got to be ready. The Uber driver doesn't wait around for anyone. If there's no food delivery, if you're not there, you're in trouble. He peaks about 90 minutes after the start of his shift, and he sticks around about twice that, so 3 to 4 hours. He's your ultimate gig worker. He's quick. He's on the site soon. But what happens if you don't have that patient tray or you don't have any food and the patient will go into hypoglycemia? So it's really important that with rapid acting glucose, I mean, with rapid acting insulin, that you give the patient their meal right away. That's very important. The next type of insulin that we have that substitutes is the short acting, and he's pretty regular acting. And short or regular, those are usually interchangeable terms. That's why he's regular acting. It takes him about 30 minutes to an hour to get to work, kind of your average commute. He peaks about 2 to 4 hours, and then he lasts about 6 hours, kind of your average, short working day. He's good IV. Only most things will say that only regular IV or short acting can go IV. Then you have intermediate. Intermediate acting is between short and long. She's moody. Some would say she's cloudy, and it takes her a while to get to work, 2 to 4 hours. She takes her time. She gets called in. She's like, yeah, give me a couple hours to get ready. And then she takes her time to get there. So it's about 2 to 4 hours for her to get to work. But then she hits her stride about 6 to 8 hours into her shift, and she'll work a full 12. So, there's that. She mixes it up with regular okay, but you want him to enter the syringe first. So let's talk about that. So intermediate insulin is between short and long. It's cloudy. It's the only cloudy insulin. It takes a while to get to work, usually 2 to 4 hours, and its peak is about 6 to 8 hours after her shift. And that'll last about 12 hours or more. She mixes it with insulin, with regular insulin, but you want him to enter the syringe first. So when you're drawing up insulin, you want to draw up the clear insulin first. So you can put short-term insulin and intermediate insulin into the same syringe. So you don't have to stick your patient twice, but you need to do the first insulin. The first one you need to pull up is going to be regular. And then you can pull up intermediate. And I think the one way to think about this too is if you're pulling up the regular insulin and you pull back a little bit too much, you can squish that back in and it's not going to make your cylinder of insulin cloudy. It will just keep it clear. But so that's clear before cloudy. And the way to remember that is regular, which is short, or regular, R, or intermediate, and those always have an N in them. And so that would be N. So, think nurse, RN. So be clear before cloudy. Then there's long acting. It takes him about 3 to 4 hours to even show up, and then he's consistent. He doesn't peak, and he'll work a total of up to 24 hours. So long acting insulin is basically like a basal insulin, but often give that at night for nighttime coverage. And so that just kind of hangs out. Just a low dose for coverage the whole time. Mr. Insulin is the only one that can let in glucose. So one day he gets sick and he doesn't show up to work at all. The people inside the building are starving. They kept calling DoorDash for glucose delivery, but Mr. Insulin wasn't there to open the door. So the residents started eating fatty acids and other crap. And that works out okay, but it makes a bunch of nasty byproducts like ketones and acid. And that's definitely not good. And so Mr. Insulin is pretty good at keeping potassium in the building where it belongs, but now it's just going everywhere. It's no longer in the cell. It's just going all over the street, in the bloodstream, everywhere. And meanwhile, the glucose deliveries keep backing up into the bloodstream and into the street. And so let's unpack that. So insulin is what lets bring glucose into the cell. Oftentimes with DKA, That's what precipitates a crisis. Someone will they'll get sick and they will end up needing more insulin, and they don't necessarily give it to themselves or they don't give themselves enough. And without insulin opening the door to glucose, the cell's going to start starving. It's going to continue to call for more insulin. It's going to continue to send out the distress thing, and the body's going to continue to do gluconeogenesis. It's going to keep pushing those glucose deliveries, but it's not going to let people in because the cells are still going to be starving because there's no insulin. So the residents start eating the fatty acids and the other stuff, and that creates those ketones. And that's where you get that ketone in the urine and things like that. So now the food city is flooded with glucose deliveries. So you get really high blood sugar. You've got acid everywhere from the keto acids, and ketones are in the sewer. They're going, that's where you can see ketones in the urine with that. And people will start breathing fast due to all the acid in the air in the city. And so that's those Kussmaul respirations, and that's DKA. So we have high blood sugar, high potassium, metabolic acidosis, and to help dilute the sugars, the acids, we add some normal saline. It's like we're rinsing the city out, rinsing out the bloodstream. We're helping to dilute everything. Eventually, we'll add some regular or short-acting insulins and potassium if necessary to get that sugar back into the cells and to help get the potassium back into the cells. So what's our teaching on DKA for our patients? And it's this: monitor those blood sugars and take your insulin. Most of the time, people have DKA situations when they've not been managing their blood sugar. And then they end up in the ICU, and that costs lots and lots of money. So if we can get them to monitor their blood sugars, or even get them an insulin pump and one of those insulin monitoring devices, it's a whole lot cheaper than ICU admission. So in our story, we had 4 different kinds of insulin. There's rapid, there's short or regular, there's intermediate, which is between short and long. That's the cloudy one. And then there's the long-acting one that lasts 24 hours and doesn't have a peak. Some of the things you need to know is with insulin, you never aspirate the site, so don't pull back on the syringe. It can cause trauma to the tissue. It can cause it's just not a good idea. Don't add heat to it, and don't massage the site. That you give, don't massage the site that you give an injection to. Those are going to be some NCLEX questions. So like a patient says, hey, I should massage this after I give my injection. You're like, no, don't ever massage your site after you give an injection. You do want to memorize your peak times. These will pop up on NCLEX questions. They'll probably pop up on your exam here too. So note these peak duration times vary a little bit depending on the type and the manufacturers. For your pharmacology review course, this one here, I've used the times that are given to you by Professor Bays in your presentation notes, so that you don't, you're learning what might be on your next test. NCLEX questions might ask questions like this, though. Lispro was given to a patient. What must the patient watch out for if the patient's tray isn't ready? Well, let's take a look. Where is Lispro? Lispro's up here, right? It's got a really fast time. It's 45 minutes peak time. It starts working 15 minutes. It peaks about 45 minutes to an hour. And if that tray isn't ready, this patient's going to have hypoglycemia. Does that make sense? This is what you're going to see on those test questions. It's not going to be so much about specifics to a single drug. It'll be like, okay, what do you know about Lispro? You know that it's rapid acting, or aspart, or glucosamine. We'll look at those in just a second. Or if a patient was given Humalog R, when should the nurse watch out for hypoglycemia? And so you're like, Humalog R is for regular. And you're looking here and you're like, okay, where is this peak? And it's going to be somewhere between 2 and 4, so maybe about 3-ish hours. And so 2 to 4 hours is the peak. Does that make sense? That's what you need to know. So this is a gold. This chart is gold. That comes from Simple Nursing, and that is in my notes down below. So here's some easy memory, easy med to remember. Here's a great little video for it. It's about a minute long, and I just put it here because it goes really fast. So here's how you can remember the rapid-acting insulin. It's primarily Lispro, aspart, and glucosamine. Rapid-acting doesn't lag, L-A-G, C-D-L-A-G. Also think log. Most of these end in log, Humalog, Nova log. So you can think of logarithmic growth. So you get rapid growth Logarithmic growth is lack of growth or rapid effect. And so the onset is rapid. It's within 15 minutes. It peaks about 1 to 2 hours. There's a duration of 3 to 4 hours. So you want to eat right away, 5 to 15 minutes after eating. Make sure their tray is present and the patient is willing to eat their dinner. They're like, oh, I'll get to it in a little bit. They might be passed out in a little bit. They also use rapid acting in insulin pumps because they can give out just a little bit of a little tiny bolus at a time, and it works pretty instantly. So then the little automatic pumps will sense the insulin level, give a little pump, and then kind of do it that way. It can also mix this with NPH if you want. Sometimes you'll see an order for that. That's the normal. Let's see. NPH is the intermediate here. So we'll talk about that in just one second. So remember regular or short acting. And the way I think about this is or short, because sometimes these terms are used interchangeably. It's regular or short. And their onset is 30 to 60 minutes. They take 2 to 4 hours. Duration is 5 to 7 hours. You will see this over and over again, that regular is the only one for IV. Learn that, know that, but it's not true. But you need to know that for your exams. I'll talk about that in a minute. You want to get this one 20 to 30 minutes before a meal. It can be mixed with NPH as well. And so if you want to go back, we'll slide up here. We'll look at these charts again. So you're like 1 hour, you're like 3 hours, and NPH is what? Like 6-ish hours, 6, 7 hours in there for their peak times. So, intermediate. Note the little n in here. These will all have n's. Novolon N, Humulin N, NPH. It's intermediate. So think the N for intermediate. N also means not clear. It's the cloudy one. And then if you want to draw it up, it's regular, then intermediate. So clear before cloudy or regular before intermediate. Onset 2 to 4 hours. Peak 4 to 6 hours. Duration 10 to 16 hours. It can be given after a meal. It's often given twice a day. This is our last one. This is the one that has no peak, and this is long-acting insulin. And I like what to hear. So it takes a long time to repay back a large debt. And so you have insulin glargine. I think the word large is in there, and insulin detamere. And so you think large debt. It can't be combined with other types. So you want to think leave Lantus alone. So here's Levemir and Lantus. So leave Lantus alone. You can't mix these two types of medications. So they need to be drawn up in 2 different syringes. Onset 3 to 4 hours. It has a continuous action. There's no peak. Its duration is 16 to 24 hours. So it helps maintain blood glucose levels regardless of meal. It's often taken at bedtime. It's a basal insulin. It's just kind of the normal range insulin, sort of functioning for like a little bit of the baseline, for a baseline amount of insulin that a pancreas might produce, that's not been excited by the fact that you just ate something. So clear before cloudy, you can drop NPH. You can drop NPH, which is cloudy. So you want to draw the regular first and then the cloudy. So draw regular, clear, NPH is cloudy, clear before cloudy, regular, NPH, RN. So you got that. Okay, we're going to talk quickly about oral diabetes and agents. I don't know how much Professor Bayes wants you to know about this. So we'll go through here, and there's some, this is a pretty good example here. I would take a look at this a few times. The things I would take a look here is this one right here, risk of hypoglycemia, because sometimes you'll see this popping up as a test question, especially with metformin. And then you might want to take a look at here and see, hey, when are these contraindicated? Or the other thing you'll take a look at is, weight gain or weight loss. Some of these have weight loss, some of these have weight gain. So I wouldn't necessarily go too deep in here, but I would talk with Bayes to find out what you need to know. But this is what I think you should know, because these are the questions that I've seen. So in general, you want to know biguanides, and the example here is metformin, which is glucophage, It reduces glucogenesis, so it stops the body from making as much glucose. You can think of metformin or Met4 big dudes. It can cause weight gain. So that's one teaching. There is low risk of hypoglycemia. So you can skip meals and so forth with hypoglycemia, with metformin method. So this is a teaching. This is a question you might see sometimes. Can a patient skip a meal? Yes. Is there a risk of hypoglycemia with metformin? Not really. It can increase the risk of lactic acidosis, especially if people are drinking with it, so no drinking. It has major liver and kidney toxicities. And because it has major liver and kidney toxicities, it can increase lactic acidosis. It can also kill the kidneys if, and especially if, it's taken with contrast dye. And you will always see questions on this. So you need to know this, and that's why it's in red. It's always contraindicated with CT contrast dye. The combination is toxic to the kidneys, and so you want to hold it for at least 48 hours afterwards, and you want to hold it before for as long as you can in 48 hours afterwards. So if they're got to go in for like a procedure that needs contrast dye, like a cath or cardiac cath scan, and going in and doing a cath lab, the cardiologist needs to know that, and they may be like, well, it's either we do this and the patient or the patient dies. And so they might be like, okay, well, we're just going to try to be super protective of the kidneys. And so they'll do that. So it's really, but you need to know this. This is gold. You'll get questions. Sulfonylureas, there's going to be glipizide, glyburide. You can note the prefix in there, which is glip or gly. You think glucose, GLY, GLI, GLU, right? So it's glucose. Mechanism of action, it increases insulin release from the pancreas. It's hard on the heart, can cause sunburn. Don't drink with ethanol with it because it can cause flushing, palpitations, or nausea. These are called like these are so not good. It's teratogenic, so contraindicating pregnancy. Meglintides, uh, and you can look at the note here and the suffix. It's glycine. And the mechanism of action is that it increases insulin release from the pancreas, kind of like most of these, right? So you can take before eating. You can skip it if you're skipping a meal. It can cause hypoglycemia if you take it and you don't eat afterwards. So this one can cause hypoglycemia. So that's like you want to know that. So I'm going to go ahead and make that one raffle. Alpha glucosidase inhibitor. This isn't ACE in ASE, so that means an enzyme, and it's an enzyme inhibitor. So what does it do? You can break it down. The name of it is arcarbose. So you can break it down, A for no in Greek, carb for carbs, and os for enzyme. So this is a, what does it do? No carbohydrate enzyme. And that's what it is. It's an alpha glucose inhibitor. It has no carbohydrate enzyme. And so it breaks down the absorption of carbohydrates by preventing complex carbs from being broken down into monosaccharides. And if you remember starches, which are complex carbs, they get broken down into monosaccharides, and then the body can use those for simple sugar. Well, this prevents that. And so it can cause GI issues because now you're basically eating a bunch of complex carbs. And if you're not breaking them down, the bacteria in your colon are breaking them down. So it's going to cause you like farts and gas and flatulence and maybe some tummy troubles and diarrhea. But it doesn't cause hypoglycemia because you're getting enough simple sugars from other things. So, and then here's one more, and this one's called extenide Brietta. And this is a question that'll probably come up on your exam, and you don't combine this one with insulin due to the risk of hypoglycemia. So I think Xana on the exenatide with insulin, Xana on the exenatide. So just remember, you want to know that one because there may be a question, Xana and exenatide. So let's walk through a couple of questions quick. There are a couple of good links here. Simple Nursing, Diabetes Management. This link here will take you to a great video. It's about 37 minutes long or therefore. And here's one for Simple Nurse, Registered Nurse Sarah. And these questions came from her page, came from this link. And she's got another couple of good videos on diabetes. Again, high quality stuff. So a patient with blood glucose of 45 is sweating, cold, and clammy. Why is that important? Signs of hypo. This is, signs of what? Low blood sugar, right? This person has low blood sugar. So the patient is conscious. You see how they're conscious? What's the next nursing action? So do you recheck in 5 minutes? Like, no, because they'll probably be unconscious. Give them 15 grams of carbs. Well, maybe that sounds really good. No intervention is needed because this is normal blood glucose, and it's not. What's the normal? Yeah, if you said 70 to 100, you're great. Give the patient 15 grams of simple carbohydrate. Oh, so this is one of those questions where you want to look at all the options because if will complex carbs do it? Not really. It's better than nothing, yeah. But what do we really want to give them? We want to give them sugar. And we want to mainline that sugar right into their system. We don't want them to have to break down a carbohydrate in order to get the simple source. So we want to go with simple carbs. So look at all of your answer choices before you make your final answer. So, because this one could have been right on first blush, but it's not the best answer. This one, D, is the best answer. Okay, number two, a patient scheduled to take a morning dose of metformin. The patient scheduled for surgery tomorrow. Which of the following nursing interventions are correct? Administered medication are ordered as ordered. You're like, maybe, but what do we need to know about metformin? You're like, well, we need to know that it's contraindicated with CT contrast dye, right? And so if there is contrast dye in that procedure, we don't know what kind of surgery it is, we shouldn't be giving the medication. So should we administer the order but hold tomorrow morning? So she's like, no, because oftentimes we have to hold that dose for up to 48 hours. Should we check the patient's glucose before administering the medication? No, we need to hold that medication for up to 40 hours, and we need to find out if there is contrast. But let's say there's no contrast for the future, or maybe they're just getting like a knee replacement and there's no contrast in that. Well, great. Then we can probably go ahead and give it, but we want to hold the dose and we want to notify the doctor. So what's the follow up? How long before and after the contrast medium for metformin? Ideally 48 hours. We can't always do that though. Let's see, you administered 5 units of Humalog at 8 in the morning. What is the onset and duration of that medication? So you can go back to that really cool chart from Simple Nursing, or you can remember that Humalog. Let's see, Humalog, it's Log. This is actually a brand name, so you might not see it, but it ends in log, right? So do we know that that's fast? It's very rapid, as it's logarithmic. And so the onset of that one is going to be what? The onset of rapid acting insulin is 15 minutes. It's got a duration of 3 hours. So our answer is A. So an onset of 30 minutes of a duration of 1 hour might be closer to our regular acting folks, our 2 hours with 16 minutes, a little more like our intermediate folks, and our 2 hour duration, 24 hours. That actually is a little bit longer for our in reality, for our long-acting folks. So your best answer is A. So patient wants to take, is scheduled to take 5 units of Humalog R. So that's R stands for regular, and 10 units of NPH. And so we can mix these insulins. And so what are we going to do? So the insulins can't be mixed? Nope, we can mix them. So that one's not right. We want to draw up the R, the clear one before the NPH, which is the cloudy one, clear before cloudy. Well, that sounds good. Okay, what about this one? C. Draw up the NPH before, so this is cloudy before clear. No, that's not. And then what about draw up the cloudy and then the clear? No. Okay, so we want to do what? Clear before cloudy. Our answer is B. So we are a registered nurse. Okay, a patient diagnosed with diabetes is about to be discharged home. You're watching the patient administer insulin. Which of the following actions cause you to do re-education? These are really good questions to know, right? So let's see. They massage the site after administering insulin. Do we do that? No, we never massage the site after administering insulin. We also don't add heat, and we also want to rotate the site, and we never aspirate or pull back on the syringe. So we know that this one is a definite yes. They should This is a definite option. They should not do this. Okay, they inject it into the fat of their thighs. Is that a good spot to stick it? Yeah, they should rotate the thighs and abs, and they can do the arms. But if you want to go for the fatty tissues, they use the opposite side as opposed to the last insulin injection. Is that good? Yeah, that's good. They should be rotating the sides, right? They engage the safety after administering medication. Is that good practice? Yeah, it's great practice. That means nobody gets stuck with a needle. So what's the answer? This one. You never massage the site with insulin after you give it. All right. Which of the following insulins have no peak but duration of 24 hours? Um, Oh, she's got these with the actual names on them, but that's okay. We can take a look at this. NPH, what do we know about that? It says an N in it, so that's normal. Nova log, let's see, that ends in log, so we know about that. That's rapid. Lantus lasts a long time, and Humulin N has got an N in it, so we know that that one's normal. However, you guys will be seeing the generic names on your, I think that we know that answer is C. Even if we didn't know that, we can cross from our mnemonics up there, our memory tools, we can remember that. Which of the following insulins can be administered intravenously? Well, let's see. Can we do Lantus intravenously? No way. It's long acting. What about NPH? That one's normal. Can we give NPH? No, we can't. That's the cloudy one and it's intermediate. We can't give that, can't give cloudy insulin into a bag of saline fluid, and we can't give that one. What about Humulin R? Let's see, R is regular. Can we give regular insulin intravenously? Yeah, that's what we're supposed to do. And what about Novolog? Novolog's got that log in the end of it, so that's short active. It's rapid acting, rather. The answer here is C is the best answer. But most test questions will say that only regular or short-acting insulin can be given IV. However, Saunders and some best practices would also say that D is correct. But on your exams, you need to know just that regular is always okay for IV. So the answer is regular. But in practice or research, you might see Novolog given. And so your note from Professor Bays in her note slide says that only give regular insulin IV. So your answer should always be regular. But if you like come across this in a book, what about like rapid acting? Sometimes they give it that way. So that confused me and I needed to look that up. So when a patient is most susceptible to hypoglycemic symptoms, it's after the administration of insulin is when. So is it at the onset? No, it's not going to be the strongest peak of the efficacy of the medication, right? What about the peak? Well, that sounds pretty good, right? The peak of fat, peak time. What about the duration? That's like, going to be a while, right? Could be a long time. What about duration and peak? Don't really like it. So what's that one simple nursing image look like? I'm going to go all the way back up to this. It's such a good slide. All the way up here. When do we need to worry about it? When it peaks. And that's why these plates are up here that are like, you need to know these up here, okay? Peaks. So you need to, that's when you're going to be most at risk for hypoglycemia is when it peaks. So the answer is B. And then one more question here. I think a patient scheduled to take 7 units of Humalog R. And you give Humulin R at 9 in the morning in the right thigh. When do you expect this medication to peak? Well, what do we know about R, Humulin R? Is that it's R for regular or short. So what is the Humulin R? We go back up to that slide again with those peaks. And why don't we do that? Let's go all the way back up there again one more time. Look at our slide. What do we see? Humulin R. So it's going to be regular insulin because it has an R in it, right? R. So that's about 3 hours. Okay, 3 to 4 hours is the peak. Let's go back to our answer options. And let's see what we got. So 8:30, and let's add, about 3 hours-ish. Let's see. Oh, we administer it at 9, so we add 2 to 3 hours. So what do we got here? We got an 11 o'clock. Is that Yeah, that's probably the best one, right? What's our option? Option C. See how we get that? Cool. All right. So next time, next we're going to be looking at disorders of the pituitary gland. We're going to be looking at problems with growth hormones like acromegaly and dwarfism. We'll look at problems with antidiuretic hormone, which is ADH, which is SIADH, and diabetes insipidus. We'll look at problems and disorders of the thyroid gland, too much thyroid, which is hyperthyroid, and too little thyroid. This is hypothyroid. So we'll fix that. My notes here. And we'll look at problems with the adrenal gland. Um, with Cushing's disease, which is too much cortisol, and Addison's disease, which is too little cortisol, as well as an Addisonian crisis. And these are the main things you need to know about endocrine. So it's not too bad. Just a little, it's a little bit of work, especially diabetes, but we're there. All right. We'll see you guys next time. Bye-bye. Okay.